That's right. Thank you for inviting me. So, as you know, I had a pretty big incident last year, and I thought I'd come and have a little chat. Thank you for the invite to come and have a little chat about what actually happened, and let you know sort of my insights into what happened and what it was like to be a patient. And also, if there's time and interest at the end, maybe just to talk a little bit about some things that you may not be aware about when you're actually treating a traumatised motorcyclist. So, I really like bikes, and there's always two sides to every story, and this is sort of the second side to mine that you may not know about. So things to talk about today, like I was saying, more what actually happened, because I've told 100 different people, and the things that I learnt and how that's actually changed my anaesthetic practice. First of all, a really big thank you. The last sort of 6 months has not been fun, and it's been really great to know that the department has been very, very supportive. Just the people that have stopped me, that called me when I was at home and off work and that sort of thing, I really appreciate it. So thank you very much, much appreciated. So I'm pretty into bikes, as you know, and I sort of go off and spend my weekends, eating pies at Pie in the Sky or riding, this Thunderbolt's Way up to Walker. I've got a lot of friends that I ride with, and we do quite a few sort of interesting kind of rides together. We've been known to monopolise Wiseman's Ferry on a fairly regular basis. And I'm equally just happy to go off and spend a weekend playing on the Oxley. So this is my drug of choice. It's a 128 horsepower petrol-powered laxative. It's a Triumph Daytona 675R. It's a bit of a beast. It's actually quite manageable around town, but it's progressively demented the more you open the throttle. And it will beat everything that's in the VMO car park this morning. So on the day of the ride, this is what I had planned to do, and I had actually planned to do this ride the following day with a friend who's still on his red Ps and not overly confident. So I thought, I'll just go and check this road and make sure that it's okay. So this was the road in question here. This is the Great North Road. It goes down through Sydney. It was built by convicts quite a while ago, and it's a very narrow 2-lane country road. The surface is reasonable in some places, but not so good in others. And I'd done it about 7 or 8 times that year. But it had been about a month since I'd done it, and we'd had a bit of rain, so I thought I'll just go and check that this is all sensible and okay to take a red P plater on. This is where my accident happened, and there's a notorious section of it, and it's really the section from Laguna to Buckety there. And there's a couple of particularly named bends there that are really quite interesting, and if you do retrieval, you'll know most of them. So I was just headed off at about 11 in the morning, and I filled up in Cessnock and headed down the road. This is the bend where the accident happened, and so this is north, that's south. And it's a descending, decreasing radius left-hander, so it's going down the side of a hill, and it tightens as you go through it. This is what it looks like from the side of the road. So obviously I'm sort of hoping to go down on this side of the road. But it's not overly complicated. It's a bend that I knew about. I knew about this bend. It's not one that I had sort of given a lot of thought to, because there's more tricky bends that are further up the road from this one. The idea behind one of these bends is that you start off wide, close to the centre line, and you finish tight, close to the fog line. So if you imagine that's just one lane of traffic, and the idea is you go through it and finish tight. And this is what it's meant to look like on the day. So you can see staying relatively wide and then coming in close, finishing to tight, and then it goes back the other way. So that was my expectation of that bend on that particular day. Is pretty uneventful. I wasn't in any kind of rush, any kind of hurry. The reality was somewhat different, and that's a picture of me being retrieved, and you can't actually identify me, but it is actually me. I actually don't know what happened. I have no memory of it. I have about 5 minutes of retrograde amnesia before the accident happened. The story that I've been told, because the other driver was the only person who saw it, and he said that I was going way too fast and was well over the double lines, and I personally really struggle to accept that. Anyway, there were 3 sections of 3 crashes on that particular road on that day. and there was another crash further up the road at Lemming Corner, and that rider was okay. I think he had a lacerated kidney or something like that. He was okay. And the helicopter got tasked, and there's a paddock where they land, and there's a farmer that sees the helicopter and gets the cows out of the paddock because they're out there quite a bit. So the ambulance up there, they assessed this patient, he was fine, and then they heard on the radio that actually you should come and see the other guy. And that was me. So they got down, and I was, in their words, very quiet, so not really talking. I think I had a coma score of about 11 or 12, something like that, and quite tachycardic to 130 and hypotensive to 90 with an obviously broken leg and an obviously broken arm. And so they gave me 2 units of O-neg, sort of on the side of the road, and scooped me up to the helicopter, where I had woken up enough to tell them just my name and that I had never been on a helicopter before, which, if you've done the retrieval term, is not strictly true. So I thought that was quite interesting. So the first thing I learnt here is that amnesia is actually a beautiful thing, and I've got really 5 minutes of retrograde amnesia and nothing for 36 hours afterwards. So all the actual really juicy trauma stuff, for me, it just didn't happen. So I woke up the following night in a hospital bed with Pat Farrell standing over me, and this is literally my first memory. And I remember thinking to myself, that corner didn't really quite go as planned. And then I was thinking, oh dear, please don't tell me I crashed at Lemming's Corner. And then finally, is my bike all right? Which it wasn't. So Lemming's Corner is particularly named by Cessnock Council at the request of the Motorcycle Council of Australia because motorcyclists go off it like lemmings off a cliff. And this is it here. So it's more tricky if you come sort of south to north because you go around this 25k an hour bend, and then immediately on the other side of it there's a 15k per hour hairpin that drops about 2 metres of elevation. And that was the last time I rode Lemming's Corner, and yes, there was a guy who had come off, and he was retrieved by one of my colleagues. So there's quite a lot of things that I don't actually remember, including the accident, what it was like lying on the road, being in the ambulance, the helicopter, the emergency department. They gave me some ketamine to pull my arm straight, and apparently I was distinctly unimpressed with that and spewed all over them, but I really don't know. Theatre and recovery, the first day on the ward, I don't really remember a lot of people coming to see me and that sort of thing. And to be honest, the whole first week is pretty hazy, and I remember the sort of salient points. I remember coming back to theatre to get some KYs put in and that sort of thing, but in terms of concrete memory, it's all quite fuzzy. So I was pretty badly banged up, and the major injuries are here. So I had a sort of a comminuted multi-segment femur fracture. I did all 4 of my pubic rami. My left forearm was pretty smashed, and my left wrist, basically Josh Hunt, who looked after me, said that my carpals had just basically exploded. I had a little mark on my C7 lamina, and of course I got a really good concussion, so a decent whack to the head. This is my X-ray that was taken in the emergency department, and as you can see there's an obviously broken femur. This is only a one-dimensional image, and X-rays tell a two-dimensional story because on the lateral view it's significantly more impressive. So you can see on that there's a suspiciously bumper bar-sized bit of femur that's been pushed backwards. This was my arm, which was pretty impressive as well, and that was apparently just sort of flapping in the breeze. And this was my wrist, and you can see that there's some carpal bones that have exploded through there, and I've snapped the base off that metacarpal there. And this is my C7, which is actually, you can't really see it, and it's very subtle, but it's right there. There's this tiny little line through the lamina that the neurosurgeons decided they wouldn't necessarily do anything about. So I think you probably gathered I was probably going to need a few things done at this point. And so this is my consent form for major orthopaedic surgery. And there's a couple of things that are really interesting about this form. Firstly, I gave them an address where I haven't lived in 15 years. And also that I judge myself competent to sign it. Because in my mind I was fine, I hadn't had midazolam, it was all good. I'd neglected the head injury, the morphine, the ketamine, the whole lot. So on the night of the accident, I came up to theatre and I had a right retrograde femoral nail put in and ORIF of my left radius and ulna, so I've got now 2 plates in there. And that took about 6 hours, and I'm very, very grateful to the theatre team that looked after me on that night. It's very much appreciated. Came back to theatre on day 6 to have some KYs put into my wrist, and then 7 weeks came back to have them out. And at some point in the future, I do need to have the plate taken off my ulna because it's right underneath the skin. It's probably worth thinking, you know, that I would be a really great patient because I knew what it was all about. And this is my recovery record. And I don't know if you can read it, but I was clearly not the best patient in the world, and I'm really sorry. So patient not tolerating Hudson mask or nasal prongs, 10 litres blowover in progress instead, which I thought was a bit amusing. So I was in hospital for about a month, and so I spent 2.5 weeks on H3 and then 1.5 weeks on E1 learning to walk again, and I got out on the 28th of August. That's only really just the beginning because I was still doing outpatient physiotherapy until late November, and I was actually doing hand therapy, like formal follow-up appointments up until February, and I've seen the surgeons again at 6 weeks and then 3 and 6 months. Rehabilitation is an interesting thing. It's not fun, and you simply have to do it. For me, it really helped to get off the narcotics and the painkillers and that sort of thing, and I'm talking more about that in a little while. But you really just have to do it. And getting off the drugs was great. I suspect there's probably a significant degree of inter-individual variability with that because some people probably will find it easier if they're on the drugs. The other thing, don't underestimate how long it actually takes to get over something like this. Getting out of hospital, like I said, is just the first start. You know, it was 6 months before I could walk properly again without a limp. And you know, that's probably something that's relevant for our arthroplasty patients, that, you know, you come in and you have your knee done, and that's really just the beginning. If you don't do the rehab, you're not going to get a good outcome from that operation. And when you're on the rehab ward, if you get lapped by an 85-year-old nana with a 4-wheel walker, that's really embarrassing. So there's a few things to talk about from the patient experience. I'm going to talk briefly about all of these, in particular with analgesia, and all narcotics are not created equal, and I had first-hand experience of this. Prior to this, I had never had a painkiller stronger than Panadol, and I ended up on a morphine PCA, and I was sort of thinking, yeah, I know how to use a PCA because I've told people and that sort of thing. Don't underestimate how long it takes to load yourself up with a PCA. If you need to get up and you know, go to the shower or something like that, that's probably a good half an hour, potentially 45 minutes worth of button pushing. So it takes a long time to work, and the risk with that is that you can overshoot. So you get up, you have your shower, and then you're really tired, and you've had now 10 milligrams of morphine, and you don't have any pain. And so you just go back to bed and you fall asleep. And also what it's like to be on controlled release narcotics. So I got put on PCA hydromorphone. I was sort of a couple of days down the track, generally quite nauseous, not temporally related to the PCA, but I did feel sort of just generally, you know, a bit sick and spewy. So the pain team gave me my choice of drugs, and I requested hydromorphone. And the reason I requested that is because my clinical experience with PCA fentanyl in young guys has not been great. So I sort of thought, oh, we'll give it a go. And it's, you know, as a reminder, it's got 4 to 5 times the potency of morphine. It has a shorter time to peak effect, and that's probably relevant in a PCA type situation, because you get a response from pressing the button much faster than with morphine. It takes 20 minutes. It's possibly less emetogenic, and it's more favourable in renal dysfunction. For me, that translated as faster analgesia and less likely to overshoot. You could have 2 or 3 presses of the button, get up, have your shower, and be relatively comfortable. It means that you don't wake up in pain because it lasts for a decent period of time. So if you go to sleep, you're not going to wake up every hour when the fentanyl has redistributed, unless you're obviously fully loaded with it. And possibly less nausea. I think it's very difficult for me to call that because there's so many other things going on in terms of the concussion and that sort of thing. Controlled release narcotics. So my experience is that they don't do much for incidental pain. So when I had my fractures fixed, I didn't have any pain when I was just sitting there in the bed. It was not fun when I was getting up and walking around and doing things, but because no bones were moving, it didn't really bother me. The thing with being on Tarzan is if you don't have that kind of pain, then it basically just gives you a foggy head. So I, in discussion with the team, tried to get off those as quickly as I can. I had other reasons for doing that. I sort of didn't really want to be on them from a chronic pain risk kind of point of view and that sort of thing. So I got rid of my PCA at about 1 week, and after that I only had 2 5-milligram doses of endone, and I was off all my narcotics by 18 days. But I did take non-steroidals and simple analgesia for a few weeks after that. I was on a PPI with my non-steroidals. It's worth sort of just thinking that the first part of fracture healing is an inflammatory response, and whether being on long-term non-steroidals is appropriate is just something to maybe think about. I don't see any reason, 1 or 2 days or 5 days of ibuprofen. I don't think that's likely to cause a problem. But if you're on Nurofen for 6 weeks or something like that, that may cause a problem. And you'd probably be best talking to the orthopods about that. So the other thing is that I thought I'd talk about what some common orders actually mean. So when you chart this on someone's medication chart, what that actually means. And there was a big thing that while I was in hospital about the foreign minister doing an interview with some media organisation using emoji. So I thought I'd talk these through using emoji. So enoxaparin. Look, basically what this means is that every morning at 8 o'clock in the morning, someone is going to come and stab you with a needle. And if you're lucky, it may be potentially sharp. There's nothing that you can do to prevent this. You have to have this stuff. I was flat on my back in bed for a couple of weeks. You're going to get blood clots if you don't do something about that. But I think it's just nice to be aware that when you sign people up for this, it does actually hurt. And obviously that's kind of dose and operator dependent, but it's just something to be aware of. Regular Panadol. It sounds great. It actually works really well for pain. But what that means is that it's now sort of 11:30 at night, and the haloperidol increments that they've been giving Feral Beryl down the corner have just kicked in, and you've just got to sleep. And then someone wakes you up to give you Panadol, and it's really difficult to remain charitable at this point. The other thing is that at 6 in the morning, they'll either come in and just plonk it on the counter and hope that you take it when you wake up, or they'll wake you up to give it. So as a result, I now chart my Panadol at 8 in the morning, 12 p.m, 6 p.m, and 10 p.m. So still 4 times a day, but at times that are perhaps just a little bit more convenient for the patient. The last thing is Tarjan, and they say that this stuff is not meant to make you constipated, and it's all fine for a couple of days, and then it comes time to use the toilet. I can tell you, it's not fun. You still need to prescribe people aperients when you're on Tarjan, and I can tell you, that thing might be happy to see you, but you are not happy to see it. All right. So IV fluids, they're great while you've got a catheter in. They're not so great after it's been taken out. And if you're eating and drinking, you really don't need 80 mils per hour of fluid, because that does translate as going to the toilet about every 3 hours. And that's not much fun at all, particularly when you've got the sort of set of injuries that I did. Midazolam. So I think it's a little bit controversial in midazolam, particularly with day surgery, whether you give it and that sort of thing. The amnesia is terrific. I don't remember anything after the midazolam was given. And in the first case, I don't even remember the syringe coming off the line. And that's probably because I was absolutely off my chops on hydromorphone. Coming back to day surgery, it was actually quite difficult to keep myself awake afterwards. So I came back and I had my K-wires taken out, and I got 2.5 of midazolam and went into recovery, slept most of my way through recovery, went back to DSU, fell asleep in the corner of DSU for an hour and a half, got sent home, and then fell asleep all afternoon on the couch as well. And I just could not keep myself awake, and I actually wanted to be awake. So my practice now has sort of been to really try and avoid it for day surgery unless there's a clear reason to give it. And likewise, I don't see that there's any reason not to give it if you're an inpatient or you're coming in and you've got a hospital bed. I mean, I'm just talking from a more sedation point of view. I don't think that's a real issue if you've got a bed to go and sleep it off. Because it certainly does help your induction. We all know it's anxiolytic and it's obviously amnesic. Having surgery is actually genuinely quite anxiety-provoking, and I knew that I'm otherwise perfectly fit and well. I've given the anaesthetic for all the operations that I've had, but I still found myself a little bit nervous about coming in to have my K-wires taken out. And I suspect that's partly because I have that kind of professional insight into what it's like to give an anaesthetic. And so most people, you give them a DAS, and as far as they're concerned, they're asleep. Whereas I knew that there'd be this period afterwards where I would be relatively lucid but not remember. And I think that probably weirded me out more than the thought of anything else. It's quite surreal waking up at sort of 5 in the morning to come into the hospital and know that in 3 hours you're going to be drugged senseless. There's other reasons I think for using it. It's a lot easier to put lines in if they're not sort of trembling and crying and that sort of thing. And one thing that I'm now quite aware of is I really want to minimise the time that my patient is in the anaesthetic bay freaking out. And so there's a lot of little sort of system issues that are associated with that. And they're things like making sure that the team is there, that the consent is complete, that they have all the equipment. It's probably important that we are seen when we're in the anaesthetic bay with our patient who hasn't had anything, that we are seen to be a team, so that the patient knows that we're all on the same page. The psychology of being injured is really quite interesting. It took 3 weeks for really sink in what had actually happened to me. And I couldn't concentrate for the best part of 2 months. And my professional insight really helped me here, because I knew that the reason I couldn't concentrate was because I'd had a concussion, and I knew that it would get better, and sure enough it did. But I can imagine if you didn't know that, you'd probably find that quite distressing. Sooner or later, you do have to stop thinking of yourself as injured. And for me, that was sort of around mid-January. I'd been to Melbourne to see my sister, and I was getting ready to come back to work full-time. And you just have to put it behind you and move on. And that's a very conscious decision, and it's something that I was quite happy to do. So the other thing that I did was revisit the accident site, and I did it twice in my car, and then I did it once again, but coming back the other way. I was obviously a little bit possible or open to the idea that this could trigger memories, that it could trigger anxiety, that there could be some PTSD associated with that. To be honest, there was nothing happened at all. And I think that's good, because I've got the retrograde amnesia. I think I'm unlikely to regain any of that memory, and I'm not unhappy about that. And it's obviously a bit of a learning opportunity. So where am I now? I'm back at work. I was off work 1 day shy of 4 months in the clinic, and then 6 months to the day in theatres. And yes, I got put in Theatre 9, and I spent the whole day patching up crash motorcyclists. So there's a delicious irony in that. So in terms of my hand, that was the thing that probably slowed me down the most. I can intubate with a regular scope most of the time now, but I've been using the McGrath for people who I think might be a little bit difficult or need to have a rapid sequence. In terms of my leg, it's really not a big issue. I can walk about 10 Ks. I still can't run very well. It's not pretty. But I can, climb stairs, and I've got some cool scars and some palpable metal bits on my elbow. So that's my most recent X-ray of my leg. There's a nice big chunk of metal there, and it's all healing up quite well. And that's my arm. And this fracture here was quite slow to heal, but it's now started to unite, and so that's not really going to be a problem in the future. So the big question, which I'm sure you can probably already guess the answer to, is, am I a quick learner? And the answer is no. So I was back on my bike in around December in a very limited capacity, and we arranged a ride with some of my friends, and we had 10 people RSVP yes that they would come, and lo and behold, 30 turned up. So that's actually I was quite impressed with that. I can break it here, or we can go on and talk about bike trauma for the anaesthetist, which is about 15 minutes.
So it's 8:15.
Do you want to? Your call.
I'm thinking maybe we should break and have questions and comments, and maybe
Yeah, sure.
Save
Yeah, yep.
yep.
Yep, no worries at all. Yes.
Yes, Gary.
As the pioneer, as the one who went before you
Yes.
4 to 5 years earlier,
Yes.
I would make the observation that your being unconscious at the scene was a distinct blessing, because I can tell you now that when you're fully conscious and you're lying in the middle of the road and you can't move, and you're hoping like hell that people aren't just going to keep driving and run over you, and that when every do-gooder in creation comes out of the woodwork to impose their view of what needs to be done to the acutely traumatised person, and when you get ambulance officers who turn up and treat you like you're a piece of meat on the road that they just perform a protocol on. And then you arrive in the emergency department and it's a continuation of the same process. You really were spared the worst part.
Look, I absolutely agree, and I have no complaints about the fact that I don't remember any of it. I mean, there's a sort of morbid curiosity that would like to know what actually happened, and would like to at least remember that people did look after me, but I am in no way unhappy that I don't remember any of this. I'm not going looking for memories.
You didn't also live with those 3 seconds before the crash where you go, pardon my French, fuck, I'm going to die.
Yeah. So I did actually, yeah. So I did actually have, I'm not sure whether there's sort of, I've recovered some memory because I could have just confabulated it up. But I do have a sort of a split second sort of thought of, I remember seeing a car coming towards me. But I don't know whether that's actually what happened, or whether that's what I've been told happened and my brain has just invented that to fill the gap. And I'm not seeking any answer to that question. Yeah, Paul.
Sorry for my morbid curiosity. Has there been a report about the actual accident? You said there was
No. Yeah, so the only person who saw the accident was the other driver and his wife who was in the car. There was nobody following, there was nobody on the side of the road, no independent witnesses, and there was no skid marks or anything on the scene. I mean, the bike is ABS, it wouldn't leave a mark. So the situation is, or what I think probably happened is that I would have been close to the centre line to go in wide, and I would have delayed my turn into that turn relatively late because it does tighten. So I think probably, unfortunately, the car may have clipped the corner and touched me. It was sort of an impact with the driver's front corner of the car. As far as I know, my head went through the windscreen, but I wasn't fully across that. The bike was pretty totaled. I think in terms of the mechanism of injury, if you imagine that you're sitting on the bike, the car hit my leg, and that's probably what broke my leg. But then there's two other things. So you're holding the handlebars like this. As you get hit on the right-hand side, it jerks the wheel around to the left, and then that's going to force the bars back into your hand, which probably what smashed my wrist. And the fuel tank sits right next to your forearm when you're on the bike. So I imagine that the bike falling over onto my arm is probably what broke my arm. Yep. And then the pelvis was just straightforward deceleration onto the tank. Yep. Yeah.
Do you have income protection?
No, but I had a ridiculous amount of leave, and that's helped very much. Well, I've still got a ridiculous amount of leave, but which tells you how much I did have. Yes. So it's definitely something that I'm investigating. Yeah. By no means. Yep.
How did you go going through the airport?
Quite disappointing. It doesn't set any of it off. And I had all the X-rays on my phone. I was just daring them to stop me, and no, nothing. But working in MRI for it will be interesting in case I sort of start microwaving myself from the inside out. Yeah. Yeah.
When you were causing problems with the Hudson mask, do you remember that?
No.
What's the procedure if you've totaled your bike? What's the procedure for you bury it or?
Yeah. So the insurance company wrote it off. I haven't seen it. I don't know how badly it was damaged, but they tend to, because with a bike, because it's so small. Virtually in any kind of accident, there's the possibility of getting frame damage, and if it's frame damage, it has to be a statutory write-off. So they would have just written the bike off, and they offered to replace it, which was in September of last year, and I was sort of, don't know if I'm going to be able to ride again, and don't know whether if I can actually ride that bike, because it's relatively aggressive in terms of the weight it puts on your wrist and your knee and that sort of thing. So they actually just paid me the money. Emotionally, yes, wasn't great, but it's just a thing. It can be replaced. I mean, it's a very special thing to me, but it can be replaced. Yeah. Anybody else have any? No?
Thank you very much.
No worries at all.
Very good insight.